Great. Thank you very much. It's great to be the last one because you can see your whole talk withering away with everyone's points being made. However, it also gives the opportunity to give some perspectives and comments on the previous speakers. And mine will be from our experience over the last year in Brazil. We've been working there for 20 years in the, let's see, the pointer work? Oh, okay. So we work in the city of Salvador, where that red dot is, and that's and that was actually the forefront of the epidemic of Zika virus. So just to give a quick run through of that timeline. So in March of 2015, the first cases of Zika virus were detected in Brazil, in the city of Salvador, as well as in another region of the northeast of Brazil. Quite rapidly, we had a large outbreak of an acute exanthematous illness. And it's important to know that this is an acute exanthematous illness, because if you can look at the curve on the, let's see, if you can look at the curve on the, I'm sorry about this, let's see. If you look at the curve on the white lines, there's actually the dengue surveillance system and what cases they picked up. And you can see in the black was the passive surveillance for an acute exanthematous illness. So you can see that difference, and I'll come back to that when we talk about the clinical presentation. So then beginning in April to July, we had a cluster of cases of Guillain-Barré syndrome. This was roughly about 50 cases in a city of 3 million people. But there were also other atypical neurological manifestations that were noticed or actually admitted to the neuro-intensive care units. Then subsequently, starting pretty much in July, the obstetricians, when they were doing their routine ultrasounds of pregnant women, started to identify increased congenital abnormalities, such as the figure on the bottom right-hand side, and which shows a dysgenesis of corpus callosum. And this was actually quite a frequent numbers of cases. On the social media, the obstetricians were talking to each other, but they never communicated that to the Brazilian Ministry of Health. And then everyone knows, as a previous talked about the outbreak of microcephaly that occurred in October. So I'm going to drill down on several of these, particularly the acute infection by Zika virus, the Guillain-Barré, and about the clinical management. Laura gave a very nice presentation about the microcephaly and the potential association, and I'll come back to more of the public health implications at the end. So acute Zika infection, the evidence that we have, and this is our current knowledge gap, is really from small case series in outbreak settings. The majority of these cases are asymptomatic, as discussed before. The clinical attack rate is 18%. And for most part, it's a self-limiting illness. And you can see this is actually from, the top panel is from the YAP study, or is actually a series of case series, including the YAP outbreak in 2007, and the bottom is from a small case series during the initial identification or detection of Zika virus. And you can see the important finding is that there's pretty much rash in almost 100% of the cases, but fever in sometimes 50% of the cases. So that goes back in terms of what's happening in the pathogenesis of this during acute infection. What we do know is also about viremia is really from very small case series. This is from New Caledonia on the right-hand side. I believe a previous speaker showed it, is that the viremia, at least after the onset of illness, is fairly short, between perhaps definitely less than 5 days and perhaps 3 days. What's been coming out in both published reports as well as in the media is really this issue of the prolonged shedding. So in this study from New Caledonia, they were shedding over up to 14, 15 days. There was a recent case studies that was presented published in Emerging Infectious Disease a couple days ago, which detected virus in the semen up to 62 days. We don't know, this is all through RT-PCR, so we don't know if those were live viral particles. So in terms of the knowledge gaps, one is really the duration of viremia. One is also to inform our understanding about the transmission dynamics, but also this issue of viral shedding and what the implications of that viral shedding is on the clinical implications of that viral shedding. So then going down to the other potential sequela of Zika virus, which is this association between Zika virus and neurological sequela. So the evidence is shown in the top of this slide. What we do know is that there was a cluster of 42 cases after the outbreak in French Polynesia. This is a population of 270,000, which estimated at least the majority, more than 50 or 60%, were exposed. The second piece of evidence comes from the Brazil outbreak, where we have identified roughly 100 to 200 Guillain-Barré cases among a roughly estimated 400,000 to 1 million cases. And from all those cases, there's to date just one confirmed case published, and that was from the outbreak in French Polynesia. So the major knowledge gaps are, one is what is really the nature of this association, and this goes back to some of the issues described before, similar to microcephaly. Really, the barrier is diagnosing this post-infectious process in populations that have been previously exposed to flaviviruses. These patients are coming in 8 to 10 days after their acute prodrome, they're PCR negatives, and so how to make that diagnosis and to actually test that association, at least in populations which have been previously exposed to flaviviruses, such as in Brazil. The second is the clinical presentation and the outcomes of these Guillain-Barré cases. Because of the difficulty in confirming them, we don't have a handle of how they're presenting. Anecdotally, and this is just from preliminary results that we've done our team has done at the Brazilian Ministry of Health in Salvador, most of these patients are coming in with classic Guillain-Barré. They are responsive to IV intravenous immunoglobulin, which is good news, but however, this may be certainly a case ascertainment bias. There's an important caveat that has to be brought into this, is that now with, as many of the speakers have talked about, this co-circulation of dengue, chikungunya, and Zika. The important one is chikungunya. There has been a case report of Guillain-Barré, and actually we now are finding confounding. So in that cluster of Guillain-Barré that we've been investigating in Salvador, we've identified actually seroconversion, patients who seroconvert to chikungunya. So there is now this coalescence and confounding due to this co-circulation of these two viruses. Lastly, and importantly, along with that, Guillain-Barré sort of was a very obvious. You could just go to the intensive care unit, you could see half the beds are filled with patients with Guillain-Barré. But we also had patients who had acute demyelinating encephalomyelitis. We had patients with encephalitis that were filled those beds. We also had patients with many of the outpatient neurologists identified strange isolated sensory disturbances, paresthesias and such. So that Guillain-Barré may be just a part. But if we go back to those figures, and I think the important thing is the risk after exposure, whether it's through symptomatic or asymptomatic infection, that risk is fairly small. If you think of 42 cases among a population of 270,000 where half have been exposed, that roughly brings you to 30 cases over 100,000 as the attack rate. So the question that goes back is, what are the host pathogen and the inoculum factors, the mosquito factors that may influence this? So then I'm going to skip the part about the obstetrical complications or potential obstetrical complications of Zika, congenital complications of Zika virus, but I do want to talk about what do we have now that we have 4,000 cases of microcephaly. Certainly some of those, as Bill brought up, are cases of CMV or toxoplasmosis or syphilis that have been picked up by surveillance. There are aspects of this case presentation that may be different than CMV. For example, we don't find involvement of the hepatic system or the cardiac system or other extra CNS findings. But I think the major issue now is what do we do to take care of these patients? This is a current outbreak. We have no evidence on prognosis. There are warning signs for us. This is a study published by our group in JAMA Ophthalmology. You can see on the right upper left-hand side, the right upper side, you can see some of the lesions that we're finding in these cases of microcephaly. These cases of chorioretinal scarring, mottled pigmentation, optic nerve involvement. These are all old scars that are not fresh, juicy, inflammatory scars, but these are scars that give insights that this may be an old, burned-out infection that occurred early in pregnancy. We're seeing these scars or these type of lesions also in babies who don't have microcephaly. So the knowledge gaps at this moment is, one is how do we screen these babies at birth? How do we let's see, what's the prognosis in the future? How do we manage the severe manifestations? Bill showed us CT scan of a typical case that we're seeing throughout Brazil. You can see the CT scan in the bottom. You can see these linear calcifications. These are all foci of seizures. We're now having readmissions of our patients for hydrocephalus and seizures, and at a fairly rapid rate. So that's one of the major clinical concerns that we're having to deal with. And as Laura said, this microcephaly is likely a fraction of the burden because of the precedence with other congenital infections. And finally, I think a very important point in seeing how the families are being affected is really what are the effective interventions to provide support to families and really to address the stigma, especially with all the media and awareness about this condition. So at the let me stop with the diagnosis, but there are really important diagnostics. And having gone through these subsequent sequential epidemics or clusters over the last year, we do need a test for acute infection. We also need a test for, as Laura said, to identify intrauterine infections in fetuses and newborns. But I would make the point that really one of the most important diagnostic priorities is to have a test that, as we use for toxoplasmosis and rubella, to screen women of childbearing age for risk stratification purposes. And then the other important diagnostic test we need is really an epidemiological tool to evaluate herd immunity, to understand and project whether this will come back. And there are really important issues that need to be dealt with in the short term. One is viremia is short during acute infection. We don't know what the persistence of the virus is in the fetus and newborns. We suspect that it's actually quite short, since many of the babies are PCR negative on birth. And current diagnostic tests, and this is a real dilemma, we don't have an adequate PCR test at this point. I mentioned the importance of an antibiotic detection that was also discussed in the previous talks as well. So I think those are some of the short-term as well as long-term challenges that we have. All right, thank you very much.